Yeah, line, please.
Thank you, Sunilji, and a very good evening, everyone. I am Dr. Piyush Bansal, Chairman of the Scientific Committee of Maharashtra Ophthalmological Society, and I take immense pleasure in welcoming all of you all to the next session of case presentations by two lovely residents. Thank you to both residents to take up the mantle and shows a lot of courage in presenting online. It takes a lot of courage. We always forget to mention that. So thank you, Dr. Saili and Dr. Prachi. Wish you all the best. And a bigger thank you to their mentors, our professor and head of department of the ACPM Medical College in Dhule, Dr. Surendra Vadgaonkar, sir,
Thank you,
and
sir.
Dr. Dhyanobha Darade, sir, professor
Thank
and
you,
head of
sir.
department of ophthalmology at GMC Ambezugai. Thank you, both of you all, sir. All of
Thank
you
you,
all
sir.
have been so forthcoming, so encouraging in getting the residents to participate. And this is, I'm sure, benefiting so many of us. So not just the postgraduate students, but even private practitioners, they let me know many times that, we learn so many things that we have forgotten. So it's good to revise many of the basic concepts and whatever is happening new, thanks to the examiners that join us. And we have two wonderful examiners with us today. Uh, Thank you, Dr. Mayur Morekar, sir, my senior alumni from LVPI in Hyderabad, now a senior consultant in Bombay Hospital, a mastermind in uveitis. He's an executive in the Uveitic Society of India as well, but he likes to be very calm and grounded. Thank you, sir, for joining us on such a short notice, as well
Thank
as
you, Piyush.
dear friend, Dr.
Yes, sir.
Samyak Kutkar,
Good evening.
senior consultant at PD Hinduja Hospital, my a very dear friend. He trained from PGI Chandigarh and now a senior consultant in Mumbai. These are the go-to people in Maharashtra for uveitis. If I have difficulties, I ask them, even though I do a lot of uveitis, but I ask them myself. So thank you both of you all to be over here. And as a last note, I would like to also remind everybody who's watching in that the AIS elections will be coming in very soon in the next 10 days. And please support all our candidates from Maharashtra. I am contesting for member scientific committee as well. And please can help all our friends, all our colleagues from Maharashtra. So with this, I hand it over to the professor in charge, Professor Archana Vare, who's this is her baby. She takes care of all the PG activities. So thank you, Professor Vare, and please take the program forward.
Okay. Thank you. Thank you, Dr. Piyush. And so we'll start with the case presentation. So first we'll start with Dr. Prachi. And I request Dr. Prachi to start sharing her screen.
Yes, ma'am. If the screen is visible, ma'am?
Yeah, it is visible. You can start. No, it's not. It's not visible.
Not visible.
Okay, again, start sharing your screen.
Yes, yes, ma'am.
Yeah.
Yes.
Now make it full screen. Yeah, start presenting your case.
Good evening, everyone. I am Dr. Prachi Girvikar, third year junior resident of SRTI GMC Ambazogai, presenting you a case of anterior uveitis under the guidance.
We can't see your screen.
Stop your video and share your screen.
Sunilji,
Yes, ma'am.
can you help her?
I'm just.
It is visible,
Yeah.
ma'am.
Yeah.
Yes,
Now
yes.
make it
Yes,
full
it's
screen.
visible. Yes.
Make it full screen.
It is now visible, ma'am.
Yeah.
Yes, ma'am.
Good evening, everyone. I am Dr. Prachi Girvikar, third year junior resident at SRTR GMC Ambazogai, presenting you a case of anterior uveitis under the guidance of my mentor, respected Dr. Garade sir, professor and HOD, and respected Dr. Sheikhe sir, associate professor at SRTR GMC Ambazogai. So, 38-year-old male patient, resident of Ambazogai, farmer by occupation, came to our OPD with chief complaints of pain and redness in left eye since 3 days. Patient was apparently all right 3 days back when he developed pain and redness in left eye, which was associated with diminution of vision and photophobia. Patient also complains of pain in lower back since 2 months. There was no history of foreign body exposure, no history of foreign body sensation and sticky discharge, no history of colored halos, no history of nausea and vomiting, no history of joint stiffness and joint pain, no history of oral ulcer and genital ulcer, no history of fever and cough, no history of weight loss, no history of skin lesions. In the past history, there was no history of similar episodes in past, with no history of ocular trauma, no history of ocular surgery, and no history of diabetes mellitus, hypertension, IHD, and COPD. Family history is not significant. Patient has normal sleep, bowel, and bladder habits. General examination was within normal limit. Systemic examination was within normal limit. In the ocular examination, head posture was normal. Facial symmetry, forehead and chin was normal. Extraocular motility, full and free in all direction. So in the ocular examination, right eye of the patient was within normal limit. So I will explain the findings of left eye. Unaided visual acuity was 6/24. Base corrected visual acuity, there was no improvement with pinhole. Eyebrow, eyelid, cilia was normal. Conjunctiva, there was conjunctival congestion with circumcorneal congestion. Cornea, there is mild edema with fine keratic precipitates. Anterior chamber, there was cells and flares. Iris, muddy in color with iritis. Pupil was irregular, fixed, non-reacting to light. In the pupillary aperture, there was grayish-white reflex with posterior synecdoche from 7 to 10 o'clock with iris pigment over anterior capsule with exudative membrane present. Intraocular pressure was noted at 11 am, was 14 mm of Hg with non-contact tonometer. SAC was pattern with no regurgitation on pressure. On fundus examination, media was hazy due to corneal edema. Rest details within normal limit. So this is the clinical photograph of left eye of patient taken on the slit lamp examination. There was cells and flares in the anterior chamber with iris pigment dispersed over the anterior capsule and the posterior synecdoches are seen. So my provisional diagnosis was left eye acute anterior uveitis, right eye within normal limit. In the investigation part, CBC leukocytes counts are increased 20,000. BSL random was 113 milligram per deciliter. ESR was 12 millimeter per hour. CRP 12 milligram per deciliter, which was increased. RA factor was negative. HLA-B27 was positive. VDRL was negative. Anti-nuclear antibodies negative. Serum ACL level was within normal limit. Urine examination was normal. No pus cells detected. Stool examination, no ova or cyst of parasite detected. Skin test, Montauk's test was negative. In the radiological investigation, chest X-ray was normal. X-ray sacroiliac joints, there was inflammation around the sacroiliac joint noted, suggestive of ankylosing spondylitis. MRI whole spine with sacroiliac joint, there was chronic axial spondyloarthropathy, mainly involving dorsal spine and sacroiliac joint, suggestive of ankylosing spondylitis. In the management part, I give the topical prednisolone 1 acetate 1% eye drops 6 times a day, which was tapered off gradually weekly for 6 weeks, and atropine 1% eye ointment at night and continue till 3 weeks after the eye becomes white. This is the clinical photograph of patient taken on slit lamp on follow-up day 7. There was decrease in inflammation with improvement in visual acuity, which was 6/12, and patient was better symptomatically. Following this, patient did not return for follow-up. Thank you, ma'am.
Okay, Dr. Prachi, will you please stop sharing your screen now?
Yes, ma'am.
Yeah, thank you for a very good presentation. And now I request Dr. Samyak sir to ask questions to Dr. Prachi.
Good evening, Prachi.
Good evening, sir.
Am I audible?
Yes,
Yes, I
yes,
see.
sir.
Yeah.
Yes,
Yes,
sir.
very good presentation, Prachi, and
Thank you, sir.
very nice photographs also. Thank you.
Yes,
So this is a young farmer, 38-year-old, right? He's a farmer by profession.
yes, sir.
So I would just like to ask you from the history, was
Yes,
there
sir.
any history of trauma?
There was no history of
There
trauma,
was no
sir.
history of trauma. You confirm that, right?
Yes, sir. Yes, sir.
The other thing is you mentioned photophobia in the
Yes,
history.
sir. Yes, sir.
So it should be in the complaints of the, it should be in the words of the patient. So you can
Yes,
say
sir.
that patient had increased sensitivity to light.
Was like, yes, sir.
Photophobia is your interpretation.
Okay,
So we
yes,
should
sir.
mention that there is increased sensitivity to the light, and that is why
Yes,
he's in
yes,
photophobia,
yes, sir.
right?
Okay, sir.
Would you try and think why was there some corneal edema? You
There
mentioned
is a
corneal.
Yes, sir. There was corneal edema due to toxic endothelitis, sir. Due to the inflammation, due to the iris inflammation, there is a increased vascular permeability and vasodilatation. It will lead to the proteinaceous material deposited on the corneal endothelium. So it will the corneal edema. It is due to the toxic endothelitis, sir.
Okay, and the fellow eye, did it have any of these?
No, sir. No, sir.
No, it did.
Yes.
All right.
Yes.
I think Dr. Mayur can go ahead with the same history and clinical examination, and then we'll go on to the treatment, right, Dr. Mayur?
Yes.
Yeah. Prachi, very nice presentation. And like
Thank,
Samyak said, very good photos.
yes. Thank you,
Uh,
sir.
yeah. So, from the history and clinical examination, uh, can you tell us whether you thought you were dealing with a non-granulomatous uveitis or you were dealing with a granulomatous uveitis?
Yes, sir. From the history, there is a there was sudden history in the non-granul. My case is of non-granulomatous acute anterior uveitis, sir. So it is non-granulomatous because it is of acute in onset. There are fine capes are present on the endothelium, sir. There is a severe exudative reaction, that is cells and flares are present in the anterior chambers. Um, so I will
There is something in history. There is one positive history that you gave, which would have made us think that it is more likely to be non-granulomatous, as you found. There's one positive history that you gave
pain and redness in 3 days, sir.
in the systemic history.
Back in the back pain, sir, due to
Yeah.
HLA associated ankylosing spondylitis, sir. It is
Okay.
non-granulomatous. Yes.
So, for now, last question from me. Can you describe how this backache comes in HLA-associated uveitis? Is it there in the morning? Is it there in the evening? Is it at the end of the day? How is it?
It is in the morning, sir. It is ankylosing associated. Yes, sir. It is in the morning pain.
It's in the morning. So that is an
Yes.
important point that you have to ask when it is present. And in these cases, you will get mostly an early morning lower back stiffness. I think
Yes,
that
sir.
is
Yes,
important.
sir. Yes.
Samit, you can carry on.
Yes. So uh, the other thing, I think now that we have moved on from clinical examination and coming to a morphological diagnosis. So, like Dr. Mayur said, acute anterior uveitis, unilateral acute anterior uveitis. So, at the end of your clinical examination, it is advised that you summarize the case.
Yes.
Like in medicine, you would summarize the case before moving on. So it is, so that you can go back to what were your positive findings
Yes, sir.
once you have examined the patient. Okay. So
Yes.
this is a left eye, a young patient, male, with
Yes.
a left eye, acute anterior uveitis, and associated with low backache. So this gives clarity to your thought. This gives clarity the moment you put it forward to the examiner. So the examiner knows that you have thought it through. You
Yes.
have included all the positive findings, and you have,
Yeah.
yes, said that there was otherwise no history of trauma, though he's a farmer by profession. That's very important, especially in the rural areas. this sometimes, this can masquerade
Yes.
with some trauma or some foreign body. So you don't want to miss out on that.
Yes.
All right. So after that, you went to investigations.
Yes.
And you found CBC to be really high, the WBC counts.
Yes.
20,000.
20,000. Yes.
Any thoughts on why would the CBC be so high in this patient? Was there a foci of infection or
There
something?
was a because of the inflammation, sir. The leukocyte count is increased.
So usually in acute anterior uveitis, this inflammation is, it wouldn't be actually reflected in the WBC. Now, this count, usually if you look at the WBC counts, the range, this is more than double. So you may ask one of the physicians to have a look as
Yes,
to
sir.
why is this count so high, or you may ask him, is there an itis of infection, has he a boil? You ruled out a urinary tract infection and everything, but it would make sense that you find out, that is, did the patient have fever beforehand, any other symptoms? All right. Okay. Coming to treatment, shall we move to treatment, Dr. Mayur, or would you want to ask any, or would you add any points at this stage?
So, just one point, Prachi. So, if you can answer this question, then full marks to you. You
Yes,
said
sir.
HLA-B27 is positive. So,
Yes,
can
sir.
you tell me? Uh, uh, so, this is definitely may not be a PG level question. Can you tell me what are the two methods with which HLA-B27 is done, and which
Yes.
one is preferred?
Yes, sir. There are two methods. HLA-B27 is done by flow cytometry and PCR, sir. The flow
Yeah.
cytometry is most commonly preferred, sir.
Yeah. So flow cytometry is actually more commonly done because
Yes.
it is a less expensive test.
Yes, sir.
PCR is the more expensive test, and there
Yes.
have been cases where flow cytometry has been negative and PCR has been positive. So if you want to be more specific, then you should ask for HLA-B27 by PCR. But if you don't mention anything, then the labs will do it by flow cytometry because that is the more available test, and
Yes.
that, like I said, is the less
Less,
expensive
less
test. Okay,
expensive. Yes.
good.
Yes.
Yeah,
Thank
good.
you, sir.
Samyak, go ahead.
So coming on to the treatment, you showed in the photo, Prachi, that there
Yes.
was significant amount of inflammation. I think there were more than 2+ cells. And even the flare was so significant that you had membrane on the anterior lens surface,
Yes,
and you
sir.
had seine cave, and it was very nicely seen.
Yes, sir.
So, is there a way of titrating treatment? The starting of the treatment, when there was significant pain, there was a very severe episode of acute anterior uveitis, and given this patient topical steroids about 6 times in a day.
Yes, sir. 6 times. Yes.
6 times a day. What is the criteria, or would you have given steroids more frequently, or do you think that this kind of steroids, 6 times in a day would have sufficed? What
It is
what are your thoughts?
It is depend on the severity of the disease, sir. Severity and duration of the disease, we give the frequency of steroids, sir. If the severity of disease is high, we should start the steroids with 1 hourly. In my case, there is a moderate grade inflammation is there, so I start the steroids 2 hourly, sir.
So when you see fibrin,
Yes.
when you see fibrin in the anterior chamber or on the
Yes.
anterior lens surface, this usually suggests that there's a very severe grade inflammation. So it will not hurt to start the patient on steroids 1 hourly for the first 2 days, 24 to 48 hours. And then you can reduce the frequency over a period of time.
Yes.
The other thing is cycloplegics. You
Yes,
gave
sir.
ointment atropine in the night,
Yes, sir.
right? 1% ointment
Yes.
atropine. Right.
Yes, sir.
What are
1%.
the other forms of atropine that you can use? What are the other cycloplegics that you can use?
Short-acting cycloplegics are used, sir. That is 2% homatropine and 1% cyclopentolate we can use, sir.
So especially in acute anterior uveitis, it would be desirable that you stick to atropine with such kind of inflammation, and you can
Yes, sir.
use the atropine eye drops as well,
Yes, sir.
and that would be at least 3 times in a day
Yes, sir.
to
Yes,
give
sir.
a stronger
Atropine eye.
cycle,
Yes.
to give a
Yes, sir.
stronger cycle fusion. All right,
Yes, sir.
all right. Uh, Mayur, what do you?
Uh, Again, one question, Prachi. So, in your findings part, you said that the intraocular pressure in both eyes was 14 millimeter. So, you said by NCT, you checked it at 11 in the morning and it's 14.
Yes,
So,
sir.
uh, what would you think of if the pressure was low? Suppose in the affected eye, the pressure was like 8, 9, 10.
Yes,
What
sir.
would you then think?
In the acute stage, sir, there will be the low pressure because of the ciliary shock, sir, acute ciliary shock. In the chronic stages, due to atrophy of the ciliary processes, the pressure is low, sir.
Very good. So, if when the patient presents to you first, and if you see a low pressure in that
Yes,
eye,
yes,
then it's better to consider that this patient is going to have a rather aggressive acute course, and then
yes,
you may want to really keep the dosaging of the steroid at about
yes,
hourly, or probably in such cases, you may even think of starting oral steroids.
yes, sir. Oral.
Okay. Yeah.
Yes,
Fine.
yes.
Yes, some.
Why do you think your patient did not turn up for follow-up after 7 days?
Uh, so we asked the patient to follow up on the 14 days, sir, but he doesn't came, sir, for follow up.
So
And I can't take the photograph of the patient because of that, sir.
that's okay. But why do you think he did not follow up?
Uh,
What is your understanding?
because it is acute condition. So I give steroids for the reducing the inflammation. If the congestion on the post of in the follow up of day 7 only, there is mind reduce the congestion, sir. So the patient symptomatically feel better. So he didn't follow up on
So would he be bothered more about the congestion or more about the pain?
pain and congestion, sir. Yes, pain and
So
congestion.
congestion would go away definitely, but the
Yes,
pain was reduced by atropine, what you gave. So cycloplegic creates it has a very, very strong effect, and especially
yes,
atropine has a very strong cycloplegic and pain
yes,
inducing. So his pain got better and he didn't follow up.
yes,
What
sir.
do you expect if he doesn't follow up? What do you think may happen if he doesn't follow up? See, you're waiting for it for a month and he doesn't follow.
Yes.
How do you
Uh,
expect he will do?
it can recurrence recurrence may be there, sir. It formation of cataract, steroid induced cataract, secondary glaucoma. In the chronic state, there will be the cystoid macular edema.
So, in a case where you're given steroids and cycloplegics, the moment the patient starts feeling better, he will either stop or modify his treatment as he wants.
Yes, sir.
If the inflammation has not gone away completely,
Yes, sir.
he will restart those medicines
Yes,
because you made him comfortable and he knows that this will make him comfortable.
yes, sir.
And there
Yes, sir.
is abuse of these steroid drops. So
Yes,
you will have to sensitize him to the use of steroids.
yes,
And that if the inflammation doesn't go away and it keeps happening
yes,
in a subclinical fashion, then he will have synechiae in the longer term and all its complications. So you will have
yes,
to counsel him beforehand about what is the pain
yes,
if
sir.
he doesn't follow.
Yes, sir.
Yes,
So, Dr.
Dr.
Prachi,
Manu.
if he would have followed up,
Yes.
what referral would you then have made for him? Apart from yourself, meaning apart from the ophthalmology, which other specialty would you want
Yes,
him to
I will refer to
follow?
the rheumatologist for ankylosing spondylitis, sir.
Okay.
Yes.
There is a term for ankylosing spondylitis. Patients who are not able to bend their back, especially if it has stayed for a long time in the latter years of their life. What is that term called?
There is a fixed flexion of the cervical spine, sir.
Yeah.
Yes,
So
sir.
that is called what? Is there a term for it? It's called bamboo spine.
Okay. Yes, sir. Bamboo
Yeah.
spine was seen on the yes, sir.
Yeah.
Radiology. Yes, sir.
Okay. So again, one question, if you can answer this full marks. So apart from, so say suppose this patient followed up, everything is fine, you've tapered, stopped steroids, the patient got a relapse again, and say the patient got 3 relapses over the next 1 year, plus there is affection in the MRI and all. So apart from steroids, are there any other agents that you would want to use in such patients?
Yes, sir. Sir, immunosuppressive agents are used in such patients, sir.
So can you
Most
name 2 or 3 of them?
Yes, sir. Antimetabolites such as methotrexate, azathioprine, calcineurin inhibitors such as cyclosporin, tacrolimus, sir. And in the biologicals, there are infliximab and adalimumab, sir.
Okay. So for this patient, what would be the drug of choice?
We prefer some methotrexate, sir.
Okay, fine. Samyak, you can take over?
I think we have covered most of the points
Yes.
totally. The only thing is, if the patient does ask you, this is the time I had an inflammation, will it ever happen again?
Yes, sir.
Give you your answer.
Sorry, sir.
If he will ask you,
Yes,
he
sir.
asks you, this is my first time I have had an inflammation in the eye.
Yes, sir.
He asks you, will it happen again?
Yes, sir. Recurrent can be seen in the HLA associated ankylosing spondylitis, sir. So, uh, I counsel the patient if there is a recurrence happen and follow up, you should take follow up of the patient, sir.
Samyukta, you are mute.
Will it happen in the same eye or the other eye?
It can be affect in the other eye, sir. It can go from one eye to the other eye, sir. In the HLA associated ankylosing spondylitis.
Yes, it is alternating.
Yes, sir.
And recurrent. All right,
Yes, sir.
good approach.
Thank you, sir.
Would you like to ask her anything regarding the complications, sir? Mayur, sir?
Yeah, Prachi. So you actually told us what the complications are. Can you just enumerate them?
Yes, sir. It is steroid-induced cataracts, sir, secondary glaucoma, cystoid macular edema, papillitis, retinal detachment, macular scar, and end stage is a phthisis bulbi, sir.
So you have told us the complications of any patient with uveitis, right?
Yes, sir. Yes, sir.
In this specific case,
Yes.
HLA-B27, if left untreated, very severe disease, then what would you expect? What would happen? Would it be more, would there be more posterior segment findings, or would then this patient go into something like a ciliary shutdown or something like that?
There is ciliary shutdown, sir. Yes, sir. Ciliary shutdown, sir.
Okay.
Yeah.
And would you take any precautions while doing cataract surgery in a case like this?
Yes, sir. Because to reduce the inflammation, we preoperatively give steroids, sir. And if there are fine capes are present, we can't do the cataract surgery because of there is a no dilatation and poor dilatation of the pupil. We use the iris hooks or any pupil dilating. Yes, yes.
Okay, chalo. So last question from my end. What is the duration that you would want the patient to be, the minimum duration that you would want the eye to be quiet before you plan a cataract surgery in this case?
3 to 6 months, sir.
Okay, good. I see. It's good that you said 3 to 6 months. So generally, it is 3 months. In any
Yes.
uveitis, we say 3 months should be the minimum period that the eye should be quiet before we
Yes, sir.
plan cataract surgery. But
Yes.
especially in HLA-B27 uveitis, the longer the better, because this is one of the most treacherous uveitis. You may have a completely quiet eye, and then whatever gory stories that we hear about complications after cataract surgery, they mostly happen in this form of uveitis,
Yes.
HLA-B27 uveitis.
Yes,
Okay,
sir.
these patients can go really downhill after surgery, and if not managed well, can end up with phthisis bulbi. So
Yes,
three
sir.
to six months is a better answer to give than just to say about 3 months. Okay,
Yes,
so
sir.
good.
Yes, sir. Yes, thank you, sir.
Samek, you want to ask anything?
Yeah.
There are other seniors also present, Madam
Yeah.
Archana,
Yeah.
Madam.
No. So with that, we can move to the next case. But before moving on to the next case, I must congratulate Dr. Prachi because she answered so well. And Mayur sir said twice that if you answer this, then you'll have like 10 on 10. But still, you
Yes,
answered
you
all
already
those
given 10
questions.
marks.
Yeah.
I already
So,
given 10 marks.
so
Thank you, ma'am.
congratulations to Prachi and congratulations to her mentor, Darade sir and
Already, sir, Sudha.
Hmm.
Congrats.
Thank you, sir. Thank you. Thank you.
So you
Good
have
teacher.
mentored your student very well. So congratulations to both of you. And now, with Dr. Piyush Bansal's permission, we can move to the next case. So yeah, so next case will be presented by Dr. Saili. And her mentor is Dr. Surendra Vadgaonkar sir. And I request Dr. Saili to start presenting her case.
Yes, ma'am.
Yes, your screen is visible.
Yes, doctor.
Yes, ma'am.
Yeah,
Yes.
go ahead.
Uh, Good evening, everyone. Today I'm going to present a case of recurrent iridocyclitis both eye. I'm Dr. Saili Boa, Junior Resident 3 of SCPM Medical College, going to present the case under guidance of Dr. Vadgaonkar sir, uh, uh, respected professor and HOD in the department of SCPM Medical College. My patient, 55-year-old female, residential of Ammaner, presented in OPD with diminution of vision in both eyes since 1 month. In HOPI, onset was sudden, associated with eye pain, redness, watering, for which she was visited private clinic previously, and she had taken treatment in the form of Moxie with Dexa eye drop, and she was partially relieved with symptoms. And there was no history of colored halos, diminution of vision in the evening, vomiting, severe headache and eye, no history of trauma, no history of painful imitation of movement of globe, no history of discharge from eyes. Um, in the past history, uh, she had a similar episode in the past, 6 months back, for which she had visited private clinic and she had taken a treatment and partially relieved with symptoms. There was history of diabetes since 12 months and on treatment with oral hypoglycemics. No history of TB and leprosy. In personal history, her sleep was disturbed due to pain. Bowel bladder appetite was normal. No history of addictions. And family history, there is no significant family history. General examination, patient is conscious, oriented to timeless person, vital stable. Vision in the right eye was hand movements close to face, and in left eye 618 with best corrected visual acuity was 6.6 with spherical plus 1.25 diopters spherical, and cylinder plus 2.25 diopter at 170 degree. On examination, ocular adnexa was normal. Leads uh, in the right eye, leads conjunctiva cornea is normal. Anterior chamber, normal content, but shallow anterior chamber with Van Herrick's method. It was grade 1. Iris, there was muddy iris. Pupil, irregular, constricted, approximately 1.5 millimeter diameter. Non-reacting, total posterior ring synechiae, seclusive pupillae. Pupillary area fibrin material was seen in the pupillary area with grayish white reflex lens, not able to see the details due to fibrin material. Extraocular movements were normal and ciliary tenderness was mild. In left eye, lids conjunctiva cornea normal. AC normal content shallow with Van Herrick's method grade 2. Iris, muddy iris. Pupil irregular, constricted, 1.5 millimeter diopter. Non-reacting partial ring synechiae was there with festoon pupil appearance. Pupillary area fibrin material, grayish white reflex, and lens IMSC. Extraocular movements normal. Ciliary tenderness was mild. So this was a picture of the right eye and left eye. In right eye, there was total posterior uh, uh, posterior ring synechiae, and in left eye there was festoon pupil. IOP in right eye was 48 mmHg on applanation tonometer at 9 am, and gonioscopy grade 0 angle. Left eye 12 millimeter Hg applanation tonometry at 9 am was taken, and gonioscopy grade 2 angle. Based on history and examination, my diagnosis is recurrent iridocyclitis with both eye, with secondary angle closure glaucoma, with pupillary block with complicated cataract. Investigations done was tuberculin test, ANA, CRP, HLA-B27, VDRL, ESR, Triple H, which was negative. CBC, chest X-ray, sacroiliac joint was normal. RF factor was positive. There was mildly raised WBC count. HLA B27 PCR negative, CRP negative, RF factor 46.1. B scan was done. Uh, there was no significant finding in the B scan. We could take the OCT of the left eye, and there was a CD ratio of 0.6. Due to raised IOP, iridotomy procedure was done in right eye. And after iridotomy, IOP was 60 mmHg by applanation tonometry at 9 am. Treatment was in the form of moxie-dexa eye drop 2 hourly, atropine 1% eye drops TDS, tab Dimox BD, and syrup Kizol was given. Brinzolamide and Timolol eye drops BD was given. Procedure done is YAG laser peripheral iridotomy in right eye. So final diagnosis is based on history and examination and investigations. It is autoimmune recurrent iridocyclitis both eye with the secondary angle closure glaucoma with pupillary block with complicated cataract. Thank you.
Thank you, Dr. Saidi, for a good case presentation. And I request you to stop sharing your screen now. And I request both the examiners to ask questions to her. Please stop sharing your screen, Saidi. Yeah.
Yes, yes.
So, yeah. So, Dr. Samyak, will you please start?
Yes, thank you, Dr. Archana. Dr. Saili, very good presentation. So, just a few clarifying points. Were the both eyes affected simultaneously? You said that the patient presented with bilateral presentation.
Yes, sir. Yes, sir. Yes, sir. So both
Okay.
eyes were affected simultaneously.
All right. And could we know what the anterior chamber looked like? Was it inflamed? Because I think
No, sir. No, sir. It was not inflamed because when she came, there was already 1 month had passed, and she had already taken a treatment previously in private clinic in the form of Moxie and Dexa eye drop. So
so
there
there
were
were
no
no
there,
cells, no flare,
no cells, no flare, no KPs. We
nothing.
could not make out.
So what do you think was the reason for her symptom? What do you think was the reason why she presented to your clinic? What is your thinking? If there were no cells, if there were no flare, and you said there was no active inflammation in either of the eyes,
Yes, sir.
so what
So
was her? Why did she present?
she basically presented to us for diminution of vision and mild pain.
Pain. So
Pain
what
and
was the
diminution
reason
of
for the
vision.
pain?
Pain and
Agreed with definition of vision, but what was the reason for her pain? What do you think? You have a clue in the examination or history?
Yes, sir. There was ciliary tenderness present, mild
Okay.
in both eyes,
Okay.
and when she presented to us, there was in right eye there was total 360-degree occlusive pupilla was there, and her IOP in the right eye was 48 mmHg.
Right.
So this could be the reason.
This could be the presenting. The high pressure in the eye could be the presenting factor for her to get it. And what about the fibrin? You said there was fibrin in the pupillary area.
Yes, sir. Yes.
So do you think it was active inflammation or you do think it was not an active inflammation?
So I think she had a attack of acute iridocyclitis 1 month back, and she was partially relieved because of the Moxie and Dexa eye drop. There was no anti-glaucoma medication or any with her at presentation.
Or any cycloplegics given in the past?
No, sir, no.
No. Okay. And you said she also had an attack 6 months ago.
Yes,
Similar kind of an attack.
yes, sir.
Okay. So this fibrin that you were seeing is not the acute fibrin that we saw when Dr. Prachi presented in the first case. If the
Yes, sir.
fibrin, if the inflammation doesn't resolve, the membrane would form in the chronic phases. So that's
Yes,
what you're seeing,
yes,
right?
yes.
All right. Dr. Mayur, your few questions.
Uh, so, yeah, am I audible?
Yes, sir.
Yeah. So, see, just can you name for me? So, in Prachi's case, we had a non-granulomatous uveitis, and we saw how it was HLA-B27 related. Can you name for me some of the causes of granulomatous uveitis?
Uh, uh, so sarcoidosis,
Yeah,
tuberculosis, leprosy.
yes, yes. One more. Sarcoid is non-infectious. TB and leprosy are infectious. Is there any one more non-infectious that you can think of, uveitis that would come as uh, granulomatous? Fine, I'll complete the list for you. VKH can come as granulomatous uveitis, VKH disease. Toxoplasmosis can come as granulomatous. So now, see, when you are presenting this, it is a partially treated case. You have not mentioned anything about the KPs. That's probably because you haven't been able to see any because it was partially treated. Suppose you had the records of
Yes.
the old records, the 6 month records, then would you want to dig into those records and find out what type of uveitis was she affected with initially?
Yes.
Yeah. So there you would like to find out whether it was non-granulomatous or granulomatous. Even in this attack where she has been treated partially, it may be good to find out whether it is non-granulomatous or granulomatous. Okay. One more thing that you just mentioned. So when you were talking about tablet Dimox, it is a very basic question. You said she was given syrup Kisol along with it. So can you answer for me why Keysol is given along with Diamox?
So
Very
because
basic question.
Diamox causes a potassium disturbance,
Yeah,
so that's why potassium supplement is added.
yeah. Very good. Very good. Samyak, you can carry on.
So now that Dr. Mayur suggested that you could look at the old reports, his old documents, this lady's old documents. She's a 55-year-old female, and say she was found to have granulomatous, bilateral granulomatous anterior uveitis. So how would you have proceeded? You have done some tests. How would you have proceeded with that, with those investigations? What would be your line of thought?
Yes, so I would like to go for test like VDRL, CBC, basic test, and tuberculin test.
Yes. So let's stick to the common parts. You said, what are the granulomatous inflammations? You enumerated those. Yes.
Sarcoidosis.
Sarcoidosis. So for sarcoidosis, what would you do? What would you look out for in sarcoidosis?
So for
Yes.
sarcoidosis, I would like to ask the patient uh, uh, to go for chest X-ray, whether there is hilar lymphadenopathy or not.
Okay, very good.
And I would like to ask symptoms or symptoms like is there was parotid swelling or uh, due to Hereford's disease, there is involvement
Okay.
of the parotid.
Okay. Any lab test, any blood test that we would ask?
So ACE
ACE levels.
levels.
ACE levels. Okay. And better than a chest X-ray, you would see subclinical lymphadenopathy on a CT chest. So a high resolution CT of the chest would also help. You have done a Montu test, which has come out negative.
Yes, sir. Yes, negative.
So why do you think the Montu, suppose the Montu is negative, what do you, how do you interpret that negative Montu?
Uh, so negative means there is no active infection.
No, with respect to tuberculosis and sarcoidosis, with respect to TB and sarcoid, how would you interpret a negative Montu? For example, a positive Montu is, what is the range of a positive Montu? Did you actually look at the test? When you did the test, did you look at the measurement? How much was it?
So 0.1 milli-international units intradermally was given,
Okay. Uh-huh.
and two, I mean double the size uh, if there is an inflammation.
All right. So you need to know how do you measure the Montu test. One is how do you do the Montu test, and how do you measure it? How do you interpret it? So what when you're interpreting the test, what do you see?
Uh, so there is a
Yeah, you know
inflammation.
it. Just you know it. You just need to uh, think about it.
So if the active inflammation is there, there will be the skin will be red, inflamed at the site of injection, and it will be double the size which we have marked.
All right. So you look at induration. Let me give you a clue. So you look at the induration and you measure the Montu, right? Like 0 into 0, 1 into 1 millimeters, 10 into 10, 15 into 15. So that is how you will interpret. So you'll have to read about Montu test and how it is interpreted. And to answer that question, how would a Montu in sarcoid will be? It will be negative
Yes, sir.
because of the energy.
Yes.
All right. So any other granulomatous panuveitis, one of the causes of granulomatous uveitis, which you said was VKH,
Yes,
which is
sir.
non-infective. How would you rule that out?
Sorry, sir.
How would you clinically evaluate?
So first I will ask about the symptoms associated with the VKH. There is a poliosis, uh, vitiligo
Okay.
associated with that. So if it is present, it likely to be leakage.
Right. So now that you're not able to see the fundus clearly because the pressure is high, you have a synechia. Is there a way of assessing the fundus and rule out leakage, which you've already done, by the way?
So B scan.
B scan. So what would you look in the B scan?
So if the
Rule
leakage
out
is there,
leakage.
there would be exudative retinal detachment.
Very good. And what else would you look out for? There's one thing that if you see and you ask, B scan is right, exudative retinal detachment is absolutely right, but sometimes you may not have exudative retinal detachment, but you will look for something around the optic nerve. So you'll look for retinochoroidal thickening. Peripapillary retinochoroidal thickening will be a surrogate marker in case you are not able to visualize the fundus.
Okay.
All right?
Yes.
Okay. Dr. Mayur, your questions?
Yeah. So, Prachi, suppose in this case, the Mantu was positive. Okay.
Yeah.
And suppose we had in the X-ray some lymphadenopathy, and maybe you had a patch or something of that sort. Then how would you proceed?
Uh, So I would like to refer the patient uh, for a pulmonary TB expert for the further treatment and uh, for the 6 month or whatever he will need.
Yeah.
And
So that will be the TB part. For the eye, what would you do?
so to relieve the uh, uh, symptoms at presentation, I would like to go for uh, moxie with dexa eye drop, steroid, atropine, as atropine is indicated. Uh, and I would like to check the IOP also.
So here in the right eye, you had a pressure of 40 and then you did a peripheral iridectomy. So what is that? What is the nomenclature? What gets relieved when you do a peripheral iridectomy? What causes a secondary angle closure? And what is relieved when you do a peripheral iridectomy? What is that word? There is a word. It's called iris something.
Iris Bombay.
Yeah. Okay. So the iris Bombay, it causes a secondary angle closure, and when there is a secondary angle closure, you do a peripheral iridectomy, and that peripheral iridectomy will release the aqueous, and that aqueous will come into the anterior chamber, flatten out the iris, and open the angle and cause the circulation to begin. Right?
Yes, sir.
Okay. Now, suppose you are in a situation where, like you said, you got a negative Mantu, and your chest CT is showing some hilar lymphadenopathy. Okay. And like you said, the patient has, something like a facial palsy or a parotitis. You were talking about Hereford syndrome. Then what you suspect? You suspect sarcoidosis. So if you have sarcoidosis, then how would you proceed? What would be the agents that you would want to start? Would you give the patient only steroids, or would you give steroids and refer for something else?
Yes, sir. I would like to start the steroid eye drops for the eye,
Yeah,
and
yeah,
also systemic steroids are also indicated,
yeah. And
and doxycycline.
for the other part, the systemic part, what would
Yes,
you want to be started for a case with sarcoidosis? You would like to refer it to somebody
yes, sir.
whom,
I I would like to refer the patient first to medicine and then
yeah,
to again pulmonary.
yeah. So what would they start? They would start some immunomodulatory therapy or immunosuppressive therapy?
Yes, sir. They could
Yes?
start methotrexate.
Yes. So in a case of sarcoidosis, then the drug of choice becomes methotrexate. So those patients would go for that. Okay. Samyak?
Dr. Saili, don't worry. It is a complicated case. This is not a straightforward case. So don't worry. These are the possibilities that would happen. See, what has happened is that this patient had multiple episodes, was not compliant with treatment. You don't have the full history. So she's landed up with you now. So you'll have to now look at the course which is backwards, try to elucidate what has happened, and look further. So right now you control the pressures. So what will you ask her to do now? What will you be your follow-up? Suppose at this stage, this is not TB, this is not sarcoid. Your only diagnosis is just a morphological diagnosis of bilateral, chronic, or recurrent anterior uveitis. Now, how will you? Now the patient has come to you with great confidence. Now, how will you go ahead? What will you tell her?
Yes, I would like to tell her that for the right eye, we had managed her pressure. Uh,
Good.
we, as we can't see the fundus and we cannot take the OCT also for the patient, so I would like to refer the case for the VR surgery for the further management, or I would like to advise her for go for a cataract if there was a grayish white reflex but could not make out the lens details. So I would like to refer her for uh, further VR surgery.
So VR is, but you did an ultrasound, and on the ultrasound you did not find anything, right? So there's probably no active inflammation in the fundus. Now, whatever the limitation of looking through the pupil is there, you're not able to see. So you might want the inflammation to settle down. You've done a laser angiography. You will want everything to settle down. You want to see, because she's been using Moxie and Dexa. Once the Dexa is stopped, if the inflammation comes back, the inflammation does come back, then you may require to be treating her for a longer time,
Yes, sir.
right? So
Yes.
step by step. What is the other thing that you may do if you're not getting a clue from the right eye? Can you get a clue from the left eye?
Uh, so for breaking the, I mean, for mechanical synecholysis could be done.
No, if you want to diagnose and if you're not able to see the retina, you want to see if there is anything in the retina, right? And you're not able to see anything in the right eye. Would you get any clue from the left eye where you're able to see the fundus? And
Yes,
what
sir.
are the possible clues that can point towards either TB or sarcoid? So you can enumerate to us what clinical features will you look for in the retina of the other eye
Uh,
that will point either towards TB or sarcoid. So let's simplify it for you. I think if you answer this, it will be a great thing.
So for the other eye, I would look for the uh, if there is a choroiditis
Very
or
good.
retinitis associated, or is there are any changes in the optic disc due to raised pressure?
Okay. Anything other than choroiditis that you want to see? What do you see in tuberculosis or sarcoidosis other than choroiditis? Something to do with the vessels? Inflammation of the vessels. What is it called, Dr. Saini? You know it.
So the vascular inflammation
Yes.
could lead to the exudates on the retina in the form of
Okay. Okay.
exudates also.
All right. And
There
what is the
could
term?
be hemorrhage also.
They could be hemorrhage because of the occlusion of the vessel, right? and active, if there is active vascular inflammation. Is there any doubt?
Sheathing of
Yes.
vessel.
Yes, very good. What do you call it? You call it vasculitis,
Yes, sir.
right? So TB, sarcoid would both have vasculitis. So you
Yes.
look for any clue of choroiditis, which is either present or healed, active or inactive, or you would look for vasculitis, which is active or healed. So two most common things you will see. What are the other? Now, this is the last question from my side.
Yes.
If you want to look for, if you're not seeing any active vasculitis, you're not seeing any active choroiditis, you scanned everything. What is the other marker of a simple test which you can do and find out if there is inflammation or not? A
So
simple test.
CBC, ESR, CRP.
The eye test, which you already done, I guess. You've done it for the optic disc.
OCT.
OCT. What will you see on the OCT?
If there could be a inflammation, active
Yes.
inflammation, there could be retinal edema.
Macular edema. Very good. Cystoid macular edema. And if there's nothing, then you may just see cystoid macular edema, which is a marker of inflammation. Right?
Yes.
Good. I think, Siley, you tried your best. Very good. And don't worry, these are complicated cases. So not only for students, but it is a challenge even for experts. So don't worry.
Riley, before we end, can you just name some of the anti-glaucoma medications because you've used them here? Can you just name a few of them for us?
Yes, sir. Brimonidine, timolol,
Yeah, yeah,
brinzolamide,
yeah. Then brinzolamide, the cousin of brinzolamide, which you used here,
acetazolamide, but in the form
acetazolamide.
of tablet.
Yeah, that's in the form of tablet. Is there any one more that is like brinzolamide, starts with D?
Starts with
D.
dorzolamide.
Yeah, dorzolamide. So you spoke of timolol maleate, you spoke of brimonidine, you spoke of the carbonic anhydrase inhibitors, and then there is one last one which is left, which, yeah,
Latanoprost.
yeah.
But
So Latin,
even
yeah, it is, yeah,
it is contraindicated.
yeah, it is. It is generally not the first preferred agent in a case of uveitis. Okay, so see what happens in these cases. In fact, my opening sentence to you would have been that you have chosen the more difficult case because now you have two eyes to present and two eyes to deal with. So from that point of view, it is a very well presented case, and these are like Samyak was saying, these are very difficult cases for anyone to sort of diagnose and then treat. So very well done. And I think most of all, what happens is that I'm talking from my experience as a resident. Okay, so when I was a resident and whenever there used to be a uveitis patient, I would sort of run away from the slit lamp or run away from the indirect room because I wouldn't understand anything about uveitis. In fact, I had once mentioned it in a PG course that uveitis was something that I actually, for major part of my residency, I had left it on option. It was one of my option topics.
That's why you
Uh,
are now expert.
Difficult to- So now I think
Expertise is because of when you run away from the subject, then you become expert in that subject.
yeah.
That's why when you are fear about that subject and later on you go on reading in details and seeing the
Yeah.
patient, and you get confidence and you will become master in that case. That's why
Yeah.
running away from the subject is also important during the
Don't say that.
Yeah.
Don't say this in a PG
during
webinar.
not
Yeah.
not every time, but be-
Yeah.
now sir is expert in that case. And I saw that both the teacher, both expert, they have given good guidance to our students
Yeah.
Yeah.
step by step, and just
So I'm coming to you
they
for
were
a
not
feedback, sir.
horrified
I'm
to
coming to you for a feedback.
the feedback. Is excellent. It is excellent. 100
Okay,
times
before we
excellent
end,
feedback.
Dr. Saili, my last question to you is mechanism of atropine. This is a very, very frequently asked question in PG exam because atropine
Simple.
is one of the most liked drug by the
That
exam.
is my favorite drug also in exam, PGR, UGH,
Yeah.
atropine.
So with that,
It is,
yeah.
it is longer acting, more potent, mydriatic, and cycloplegic. And it also reduces the hyperemia, and it will reduce the exudates.
Sally, I think you need to read about atropine. What
Yes.
does it do
Yes.
to Sineki? So that's a small homework from my side. And with that, we would come to the end. And I request Dr. Samyak sir and Dr. Mayur sir first to give their feedback. So we'll start with Samyak sir first.
Thank you, Dr. Archana, and thank you, Piyush. And I would like to thank the guides who have mentored both the students. Very good cases. I think very well presented. Like Dr. Mayur said, the challenges in the second case were multiple than that were in the first case. But the first case also, Dr. Prachi presented it really well. Uh, yes, all examiners would be looking at your clinical signs and clinical evaluation. You should be perfect with clinical evaluation. Diagnosis, there may be times you may not be able to completely diagnose, but to arrive at a morphological diagnosis like acute anterior uveitis, chronic anterior uveitis, pan uveitis, those things are very, very important. Plus, like Dr. Archana Madam pointed out, that you should know the effects, the mechanism of action of at least atropine, prednisolone acetate. What are the precautions you should give while starting oral steroids? The side effect of steroids. This is especially in the uveitis cases. And like Dr. Mayur said about anti-glaucoma medicines, because you can have glaucoma as a complication of a lot of uveitis cases.
Thank you, sir. Dr. Mayur sir?
See, the only feedback that I would like to give, very general feedback to any student. See, what happens is, I've realized this as I've been a student. In fact, I feel I'm eternally a resident. What feedback I would want to give is that whenever you are making a presentation or whenever you are giving an exam or something, see, it's easier said now, but I don't think there is any reason to get scared or intimidated by any examiner or anyone like that. See, when you are getting intimidated at that time, you are going to probably not be able to say things which you would otherwise know. Okay, so it's always better to, just go. uh, I don't know if the other examiners would ever agree with me, but I think on the given day of the exam, the most well-read people are the students. Because they have read the entire subject probably just the day before or 2 days before. So from that point of view, I think any student should just go and answer questions. I think that is it. Should look at an exam as an opportunity to interact with a senior person and give your views about how you would manage a particular case. I think if you go that way, then that's the best thing. One thing that I liked about Saili is when you said that you would refer it to a VR specialist. And I think that's a great thing to say. When I was giving the FRCS exam, the first exam, there are 4 or 5 examiners. The first examiner, and I just said that I would refer this to an oculoplasty specialist, and that person gave me an immediate feedback that that's a very good thing that you said, because most times you want to be safe ophthalmologist. So from that point of view, it's sometimes very frank to say that I would refer this for this thing. I think that's a very good thing to say. So let it be an interaction between you and the examiner, and take it that way. I think if you do it that way, then it can't go wrong. Okay, thank
And
you.
quick feedback from Darade sir and Vadgaonkar sir.
Actually, Samyak sir and Mayur sir has told and discussed very nicely, and they actually guided us because they are expert in that subject. We have tried our level best, but till what they have told is definitely helpful to us as well as our students also. So thank you so much, Piyush sir, Mayur sir, and Samyak sir especially for discussing all the subjects in a very peculiar and silent manner. That is important. What Mayur sir was telling was the examiner. Why resident fear of the examiner? Because of their nature. So what they have told is very nicely. Thank you so much, Archana ma'am, Mayur sir, Samyak sir, and boss Piyush Bansal sir. Thank you so much.
Vadgaonkar sir.
तर मराठीत बोलू का?
Sir.
सर सम्यक सर आणि मयूर सर यांचं गायडन्स इतकं सुंदर होतं, म्हणजे एकदम स्लोली आणि सायलेंटली प्रत्येक स्टेप्स प्रत्येक गोष्टीला इम्पॉर्टन्स दिलं, बेसिक गोष्टीला इम्पॉर्टन्स दिलं. ते फार महत्वाचं आहे. म्हणजे बेसिक थिंग्स टू बी गेट कवर्ड, अँड स्टुडंट शुड सी एव्हरीथिंग इन डिटेल्स. Whenever they see the patient, they should see it in the details, and they should not present it as a diagnosis first. They should reach to the diagnosis. They should have a provisional diagnosis, and then they should make a final diagnosis. And that is important. Every finding, every symptom is important. And before going into the diagnosis, one should go for differential diagnosis. In history itself also is very important. In history, sometimes you say the redness of the eyes and you don't have differential diagnosis, then your diagnosis will be, it will be a misleading. So this should be covered by the student, and findings should be seen in details, and they should be discussed repeatedly, and then you go for diagnosis, not direct diagnosis. And both sir has asked the questions in such a manner that students, they realize that how should approach to the diagnosis.
Thank you, sir.
And
Thank
then
you so much.
treatment is the last thing. And then I would like to give thanks to Archana. She has invited us to participate in this case, and Piyush Bansal sir, they are always with us. And then office bearers, Darade sir, I have seen you since the conference Marathwada.
Yes.
Archie was also very good. I was also give thanks to all office bearer. Thank you very much.
Thank you, sir. And now I request Dr. Piyush Bansal sir to give his feedback and also propose the vote of thanks.
Well, thank you, Professor Vare. Nothing is possible without you, of course. Samak and Mayur Dada, so both our residents have passed with flying colors.
Yes.
Yes, with flying colors.
Yes.
But
Most definitely.
that just goes on to show the quality of education that we have in our state. More importantly, the teachers who are passionate enough to take the time, take the effort. We've had a lot of teachers. Uveitis, as you can see now, we always finish at 9 o'clock, and today it's 9:14 right now, and we are still smiling and in the webinar. That is because my uveitis teachers as well, whether it was Professor Annie Mathai, whether it was Amod Gupta sir, both, Samyak's teacher and Mayur sir's teacher. So, the kind of empathy that they had is that the more we learn, the less we know. So uveitis is one particular branch that invokes a lot of empathy as well as humility, because there is so much that we don't know, but we would like to know, and we would like to explore, and we would like to discuss and question. So I don't think it was possible to have any more beautiful teachers and experts. So thank you both of you all, Professor Samyak and Professor Mayur, for being there and teaching us. Professor Mayur in the calm, soothing voice, and Professor Samyak in the Terminator background voice that was there. Thank you so much. And thank you so much to our lovely, lovely mentors, Professor Drade, Professor Vadgaonkar sir, and
Thank
Professor
you.
Vare. Both of our residents, Sunil ji from Zad New Tech, and Entod, thank you so much for supporting these initiatives. They go a long way. The indirect impact of these teachings go a long way, and we will see the effects in the forthcoming years. So a big thank you from Maharashtra Ophthalmological Society to everyone.